Yeah. So why dose escalation? Yes, of course, we increase complete clinical response. We can increase R0 resection, and of course, we can also affect and select few the disease-free survival. And this has been first is a traditional approach of 5 weeks followed by 6 weeks of waiting and then surgery. And we have seen that CCR or PCR rate in these traditional studies range from 12 to 20%. And with this rapido approach, now this PCR rate has shot up to, or clinical complete response rate has gone up to 28% or more. And with this TNT approach by OPERA trial, where we give RT followed by 6 cycles of Capox, the CCR rate has shot up again to more 38%. And when we start with chemotherapy, it is followed by radiotherapy, it is 28%. So we see with even the normal doses of radiation and adding more and more chemotherapy in the TNT approach, we have achieved a good clinical complete and PAT-CR. But what about organ preservation, which will be my focus of topic, that how to increase the CCR rate by radiation dose escalation. And there was a meta-analysis published in 2018 where they compared, where they showed that the radiation, the CCR rate increased with the dose escalated RT. So the reference line is at 15 gray, and one of our studies is also quoted in that 15%, and most of the studies you see are have where dose escalation has been used, the CCR rate or PCR rate has gone beyond 15%. So techniques of delivering doses, now EBRT boost, that is external beam radiotherapy boost. There's an endorectal applicator boost, and there's a endorectal applicator with contact X-ray boost. So these are the 3 methods which radiation can be boosted. And this was a very good paper by Anne Appelt, published in Lancet Oncology in 2016, where they showed that where they had included mostly early tumors, and showed the majority were T2 and T3, and the EBRT dose was 60 gray over 30 fractions to the tumor and 50 gray to the lymph nodes, and they also gave 1 fraction of endorectal boost of 5 gray, and we see the 51 patient, the 78% complete response rate was reported. And another study by Dr. Tae Wong from Montreal, they gave, these were the patients, this was an older study in 2019, and all those elderly patients which were ineligible for surgery, they just gave EBRT dose of 40 gray over 16 fractions, and with endorectal brachytherapy boost, this is with HDR boost weekly, and their CCR rate has shot up to 86.2% clinical complete response. The tumor regrowth rate was as down as 13.6%, and with a good local control and survival. So this is something for the non-radiation oncologist, the endorectal boost looks like. The technique, this is the applicator by OncoSmart, and this is how it is applied, and this is the double boost technique by Dr. Tae Wong, where endorectally after that they give they put a balloon to push away the other wall, so we can just focus on the residual tumor, and we can give up to very high doses of HDR boost, and this is the applicator that looks like. So another study by Dr. Sunny Mint, he's also a pioneer of giving endorectal boost, but with contact X-ray, and this is from the Clatterbridge Center, and they combined all the centers, the treatment, and the very well selected group. You can see the 33% were T2 and 66% were early T3As, and this was the technique used, the contact X-ray. So the beauty of contact X-rays, it doesn't go beyond 10 millimeter, and there's a sharp fall off, and it is a contact X-ray. It is not a HDR boost or iridium or higher voltage of other rectal therapies. And this is the technique they used, EBRT dose of 45 gray, 25 fractions, and concurrent capecitabine and 5-FU, and contact brachytherapy. So this brachytherapy is given 30 gray in 3 fractions. That means 90 gray. So 90 plus 45 outside. So you're giving almost 140 gray of radiotherapy. And there, this is again, the machine looks like Papillon machine. And this is how the tumor at immediate, the pre-RT, the first image, then at 12 weeks, 28 weeks, and then at 6 months, the tumor is almost gone. And this was again, this was that. Now this look at the complete response rate with this, what they have reported is 63.8%, and sustained complete response in these patients are 86%. So again, it shows that yes, endorectal boost either with HDR brachytherapy or with contact X-ray does give rise to higher complete response rates. But this has to be proved in the randomized trial where they compared with the external boost versus Papillon boost in the contact X-ray. And this is called OPERA trial, and this was presented, the results were presented this time in ASCO this year, and where they randomized. The initial sample size was 314 patients, but they had, at the interim analysis, what they saw that the EBRT boost with EBRT with Papillon boost was doing way superior, so they were instructed by their IC to stop the trial at 140 patients, and they presented these results this year. And this is, I've taken from their slides, and look at the PCR, the CCR rate is 92% with the boost compared to 64% with the external beam brachytherapy, external beam radiotherapy boost. And the organ preservation rate is 80% in the Papillon boost versus EBRT boost. And when they saw in this next graph, you see that if the tumors were less than 3 centimeter at the end of external beam radiotherapy, there was 97% went for organ preservation. So this is a very, very high rate which has not been reported in literature till now. It's very encouraging. It's almost looking like squamous carcinoma, or maybe better than squamous carcinoma in these well-selected patients. So they concluded that contact X-ray boost combined with neoadjuvant therapy for T2, T3 less than 5 centimeter tumors at presentation significantly increased the rate of clinical complete response, that is 64% versus 92%. And especially for if the tumors are less than 3 centimeter, it is 97%. And there was no difference in toxicity between the two arm, and good bowel function was preserved in more than 80% of the patient. Another very exciting study which was presented in ESTRO last year, but they have presented only the interim results. This is led by Dr. Tae Wong from Montreal, and she does HDR brachytherapy. And again, these are well-selected group of early T2 and early T3 tumors, and they are randomizing the study, still ongoing, and they presented the outcomes interim in the first 40 patients. So EBRT boost of 9 gray versus 10 gray per fraction, that is 3 fractions of HDR boost after the completion of CTRT. And again, the boost with the HDR brachytherapy arm is way superior than the EBRT boost. So there's 90% clinical complete response rate, and regrowth rate is 30% versus 17%. So again, this we will wait for the ultimate results. So we were till 2017 as a group, when Dr. Saklani joined us, we started doing this observation. We published our results for first 36 patients where we were not using the boost. And this is the applicator. It was actually a vaginal applicator which we have modified, and we use it MR guided, where we can, after the end of radiotherapy, 1 or 2 weeks later, we can clearly see the residual tumor, and we just target that residual tumor to the growth, to the dose of 5 gray into 2 fractions we started with. And this is a typical plaque, exudative lesion we see at the end of 12 weeks. But then we continue to watch them, and we have this protocol. And so this is our protocol. At the time, we have increased now this our endorectal boost dose. And this is the protocol we follow. It is a very standard protocol. Every 3 months we have a MDT. All the patients are strictly seen by surgeons and radiation oncologists, and together at the MDT. And if there is a local relapse, they go for surgery, or if there's a partial response, of course they go for surgery. And this is a result of our first 100 patients. This paper is under publication. Initially we started with lower dose, 4 gray into 2 fractions, then 4 gray into 3 fractions. Currently we are giving 6 gray over 3 fractions. We've gone slow because our toxicity rate is very, we've not had any grade 3 toxicity till now. Grade 2 toxicity is also below 12%. And local regrowth rate with this kind of strategy is 11.5%. And our complete response is around 47%. People can go on, almost half of the patients are going. So mind you, these are all, majority of them are late T3s. So at the median follow-up of 26 months, we have a very good outcomes, and with less toxicity and disease-free survival. This is at 2 years. So again, this SIB IMRT, like dose escalation may not be limited to just to increase complete response. We can also increase R0 resection rate. We can also target these big nodes, lateral pelvic nodes. And this is currently we are investigating in our setting. And these patients are really doing well. They may undergo exentration also, but the disease-free survival rate is around 10%. These large ones with these large nodes. So I feel there is, in future, there will be a strategy to increase these doses, not only to the primary, but also to the node. And the patients who can't undergo brachytherapy, or if they find it difficult to have this applicator in situ, or it's painful, then we give them endorectal balloon, and we try to give them dose escalation with EBRT using endorectal balloon. So now you can see, if you have small tumors, T3A, T3Bs, and if you don't use brachytherapy, then the complete response rate is 50%. And if you have bigger tumor, then the complete response rate is 10 to 25%. But if you use dose escalation, these very small small tumors can with the dose escalation, complete response rate is reaching more than 75%, and these for the bigger tumors it can go up to beyond 45%. So they can go for organ preservation. So yes, dose escalation is a very promising strategy in improving the complete response rates, and is safe in terms of toxicity, and we have to have a strict follow-up schedule and a higher rate of organ preservation. And this is all possible of a good radiologist first, that is a must. They are very integral part, and of course the whole team. And yeah, thank you so much.
Yeah, so excellent presentation, madam. Couple of questions. I had, looked at some French study also presented at ESCO GI, and the way I remember it is 2 toxicity. So I would like to know from you the incidence of bleeding in this patient, and how did you manage those bleeding? Number 1, and number 2 is about the stenosis. So ultimately, quality of life assessment also after this.
So at this, patient selection is the key. So we never take these patients who have circumferential tumors, because then you have to give the full circumference and this stenosis rate will be high. So none of our patients have had stenosis in this, because we've taken at the baseline they were involving 3/4 of the circumference or less. So this is the key, and if they at all, yes, grade 2 toxicity in terms of bleeding typically develops after 9 to 10 months of brachytherapy, and we are very well aware. But they are in less than 12% of the patients right now. So there is a scope of dose escalation, and then how Dr. Tae Wong uses. So if those French people, first of all, their selection criteria may not be appropriate. Then they must not have used a balloon to push over the other normal rectal wall. So we have double balloon technique, single balloon technique. So if it's done very properly, with these modern techniques, yes, there is hardly any toxicity. And if at all, if there's a rectal bleeding, then we give them APC if they are appropriate. We give them endorectal enemas of steroid enemas, and then of course hyperbaric oxygen therapy. So till now we've not had any grade 3 toxicity. So we are very confident, and we've gone very with the lower doses. Suddenly we cannot copy the Montreal group like 10 gray into 3 fractions. But we have gone from a lower dose, building confidence, building a technique, and then going higher and higher.
Last question would be, in how many patients salvage surgery was required in your study group, and how difficult it was?
So more salvage surgery, because 55% exactly underwent, like 35% had PR in our TMH data, and another 10-15% there was like sometimes patient opted for it, sometimes surgeons were not very sure if it is completely gone. So our rate is not like them right now. It is around 45%, but with this newer and with this higher doses, I'm sure, and it's a team, like learning experience. So we are getting more and more towards organ preservation.
How difficult it was for surgeons after such a high dose?
Saklani can answer, but there is no, because see, the higher dose is just limited up to the serosa, and you are doing TME, you are going from outside. So whatever has been done inside doesn't matter to a surgeon.
So a question to probably Dr. Reena and Dr. Saklani together. What proportion of these patients, when we're talking of salvage, got converted to sphincter sacrifice from a potentially sphincter salvage situation? That's another consideration we have to do when we're talking about distal rectal cancer and definitive chemo-RT or added boost. Dr. Saklani and Dr. Reena, any of you could take that question, please.
So sphincter preservation is actually, we go by the baseline MRI. So we document in our MDT notes if the ISR planes are free, or if they are little fudged, or if they are like indenting. So in fact we find with these kind of higher dose rate of RT, the sphincter preservation rate goes higher. Saklani can answer that. Yeah.
Okay. Great. Thank you, madam.
Yeah.
It was an excellent talk.